everybody for attending and sharing your lunch hour with us. My name is Robin Green. I'm a senior scientist here at Toronto Rehab, and I'm head of the Brain Discovery and Recovery Team. So I'm going to give you a brief, just a very quick introduction and a brief overview, and then I'm going to turn the rest of the presentation over to our three speakers. I'm going to start by giving you a quick background on moderate to severe traumatic brain injury. So first I want to clarify that I'm not talking about concussions. I'm not talking about an injury for which the majority of people show a pretty speedy recovery, 7 to 10 days, but rather I'm talking about more serious injuries that have lifelong injury, damage to the brain, and often enduring impairments as a result, impairments to people's attentional functioning, memory functioning, thinking functions, their ability to regulate their emotions, very significant impact on mood, like depression, anxiety, and more. So our lab has been studying moderate to severe traumatic brain injuries, which, in case you're not familiar with it, are these, they often are sustained in the context of car accidents or very bad falls, assaults. And so we've been studying people with moderate to severe TBIs for a number of years. And we see people when they arrive at Toronto Rehab as inpatients. We follow them once they've left at 5 months post-injury. We see them again at a year and at 2 years and sometimes many years thereafter, post-injury. And we assess people. We do very comprehensive cognitive assessments of their emotional and psychiatric functioning, of their motor functioning, and also we carry out neuroimaging of their brain at these assessments. And what we found is that in the later stages, after the acute neurological effects of injury have resolved, what we see is that actually, in a lot of cases, things go downhill. So we see that the brain can atrophy across time from 5 months to 12 months to 24 months post-injury, that mood can decline, and then for many people, some areas of cognition can decline as well. However, there are a number of things that we can do for this. So we've been focusing on what we call post-injury factors, so things that we can do to help people. So let me backtrack. We've been trying to identify modifiable factors. So we can't do anything about pre-injury factors like a person's age or their level of education, but we can do something about things that come online that are contributing to this deterioration after the injury. And so we've identified a few things that we can target, like anxiety and cognitive stimulation. And it turns out that higher levels of anxiety and insufficient levels of cognitive stimulation are in part associated with this deterioration that we see in the chronic stages of injury. So what we have done recently is we've developed a clinical research center in order to deliver interventions to people right across the province, across Ontario, and there are approaching 150,000 adults who have persisting effects of traumatic brain injury. The numbers are really, really big, and people live, of course, often in very remote areas. So we've developed a center. It's a telehealth center where we're delivering interventions to people online over the internet, and we're also delivering therapies that are self-administered. Just to give you what that looks like. And this center is designed so we can get therapies to people through participation in research. And so we're tackling, our interventions operate on 2 levels. You can think of the mind and the brain as those 2 levels. So we're delivering treatments that we know that have evidence as being tried and true at the level of the mind to ameliorate symptoms of cognitive impairment, mood impairment, and at that second level, the other level of the brain, these treatments are designed to tackle the neural deterioration that we see, okay? And as I say, we're delivering treatment through participation in research. So what we're doing is we're trying to carry out research to refine these interventions, to figure out how we can most effectively get the treatments to people, how we can make the treatments maximally effective, how we can improve our response rate to treatment. And we're measuring as well the impact on the brain. And we're hoping that we can improve brain and brain function through these treatments to hopefully confer even more enduring effects of treatment by actually changing the brain. So one of the things that we're very, very attuned to is that people that sustain brain injuries sometimes are really what we would call doubly vulnerable. So people have, sometimes we're working with people who are in really unfortunate circumstances. They may be homeless, they may be in the criminal justice system, they may be contending with substance misuse. So we're trying to understand how these factors play into traumatic brain injury and how, with a better understanding of these things, we can do a better job of treating all patients with brain injury, hence the name of this presentation. No patient left behind. So our first presenter, Alana Tipples, I'm just going to boast that I've had the pleasure of previously supervising or currently supervising all of these students. Alana received her master's last year, and she's going to be talking about her master's research on traumatic brain injury and substance misuse, and she'll talk about how a previous history of substance misuse can influence recovery from a subsequent brain injury. Michael is going to talk about the complexities of TBI and homelessness. So we know that there is a disproportionate number of people who are homeless who have traumatic brain injuries, and we know this in part from one of our scientists at the hospital, Angela Colantonio. And he's going to talk about some of the mechanisms of that relationship and how the sequelae, the cognitive and neuropsychiatric sequelae of TBI feed into homelessness and its perpetuation. And then Mary's going to talk about Mary Bullis, Michael is a current student, Mary's a current student doing her master's as well. And she's going to talk about TBI and the criminal justice system. And she's going to tell you about some work that is just getting off the ground, where we're trying to figure out how to reach people who have been convicted of a crime, who are going through a mental health diversion process, and who have sustained a traumatic brain injury. And we're trying to figure out how we can get some of our interventions to those individuals and how we can measure the impact that we might have on factors like recidivism. So I'm going to turn the mic over to Alana.
So I'm going to be talking about my past thesis work on how history of substance misuse may impede recovery of attention after moderate to severe traumatic brain injury. So just a bit of a background. We all know that alcohol can cause temporary effects to the brain and cognition and behavior, but what the literature shows is that it can also cause enduring cognitive and neural changes. So for example, one study found that cognition of alcoholics was significantly poorer than those of their non-alcoholic peers that were 10 to 15 years older than them. Another study found that alcohol can cause premature brain aging, which was indicated by reduced white matter volume following chronic alcohol misuse. So reduced white matter volume is typically found in an older population, but it was found in this population of people who had been using alcohol chronically. Marijuana is something that can also cause enduring cognitive and neural changes. So many studies have found that it can impair selective attention, and this is associated with the extent of use, so age of onset as well as the amount of marijuana used. And several neuroimaging studies have found that chronic marijuana use can lead to decreased activation in attention areas, such as reduced cerebral blood flow in those areas, in those structures. So I just want to sort of mention that when I'm talking about substances, I'll be referring to these two, alcohol and marijuana. So just a brief overview of traumatic brain injury and substance misuse. To date, there has been a lot of literature about how substance misuse can lead to increased risk for traumatic brain injury due to increased impulsivity and sort of risky behavior, as well as increased incidences of falls when intoxicated. And likewise, there has also been a lot of research about how a traumatic brain injury may lead to an increased risk of engaging in substance misuse. But where there tends to be a gap in the literature is the impact of the substances on recovery after brain injury. So what we wanted to look at was the impact of pre-TBI substance misuse on recovery post-TBI. And the reason that we looked at attention is because, as I mentioned, alcohol and marijuana are both found to have lasting impacts on attention. And attention is something that those with moderate to severe traumatic brain injury often report as a significant symptom that persists long after the brain injury. In fact, 40 to 60% of people with moderate to severe traumatic brain injury report lasting issues with attention. So the objective of the study was to ascertain whether history of elevated substance use would undermine recovery of attention after a moderate to severe TBI. And so what we did was we measured substance use using the personality assessment inventory subscales of alcohol problems and marijuana problems. And what we found was we used a database of people that had traumatic brain injuries, moderate to severe. And we found a subset of these participants had high substance use. So we found that 36 people in the database had what we would label as high substance use, which was an elevated score on the alcohol and marijuana problems of one or more standard deviations above the mean. And what we did was we case matched them based on age, injury severity, level of education, and a number of other factors to traumatic brain injury controls who also had a moderate to severe traumatic brain injury but who were within the normal range for alcohol and marijuana use. So the results were really quite interesting. What we found was that when we looked at an aggregate of 8 tested attention, those with high substance use had a recovery of approximately 10% between 2 and 5 months post-injury, whereas the improvement for the control group was almost or more than double that, so on average over 20%. And for those of you who may be familiar with the tests that we used for attention, we broke it down also by each test. So, and feel free to ask me about these tests of attention afterwards if you have any questions. But we found that there were significant differences in recovery on trail-making test A, Stroop color word, Stroop word, and verbal fluency. So as you can see, there is a significant difference between the recovery of those with substance misuse versus those who are the control groups without the substance use. So just sort of another way of looking at this, we did a partial correlation between each participant's highest score on the drug or alcohol scales with their aggregate percent improvement on attention. So as you can see, those who had a score of between 50 and 60, which would be classified as being within the normal range, had approximately 20% recovery, and there is a significant negative correlation whereby the higher scores on the PAI, which are indicative of more severe substance misuse problems, are associated with lower levels of recovery on attention tests. So another thing that we just sort of looked at briefly, because once we noticed there was this this difference in recovery of attention, we wanted to sort of briefly look at why that might be. Some different looking at some different factors that we had also collected information on. So one of these we categorized as the level of stimulation. So within that, we looked at the amount of outpatient therapy hours, as well as their score on the lifestyle activities questionnaire, which is sort of like a physical activity questionnaire, but for more cognitive activities. And we also looked at their level of activity, which was a scale that was developed in the lab that basically just looks at a description of the participants' average day, and then we give them a rating from level 1, which is primarily resting, watching TV, sort of taking it easy, to level 3, which would be sort of where we're at, going to work, volunteering, socializing, that kind of thing. And as you can see, though both groups are primarily not at a level 3, which is to be expected at the 5-month post-injury level, the non-substance use group was primarily at a level 2, whereas the substance use group was still primarily at a level 1. So another thing that we looked at was motivation, and we used a scale on the PAI to measure that as well. And what we noticed, interestingly, was that there wasn't a significant difference whereby both the substance misuse group and the controls were sort of similarly motivated to participate in their rehab and positive about their feelings that the rehabilitation could help them. And lastly, what we looked at was social support, and we looked at that using the socioeconomic status, their insurance status, and as well the level of non-support, which is another scale on the personality assessment inventory. And interestingly, we did notice there was a significant difference where the substance use group had significantly higher feelings of not being supported in their environment than did the control group. So the key takeaway from this study was that elevated pre-traumatic brain injury substance use was associated with reduced attentional recovery post-traumatic brain injury. And so we wanted to sort of just discuss some of the possible explanations. So one would be a pre-injury factor that was just the organic damage to the brain from either the marijuana or the alcohol or both, which may have led the brain to become more sensitive to the injury when it occurred. But we like to focus, as Robin said, we like to focus on post-injury factors because they can be modified sometimes. So as we noticed, there was a significant difference where the high substance use group had lower levels of support and lower levels of cognitive stimulation. So the rehab implications for this are that we believe that the individuals with history of substance misuse may be returning to post-TBI environments that might be lacking in social support and cognitive stimulation. So it might be a good idea to provide them with case managers and referrals to support groups that may be joint support groups for substance misuse and traumatic brain injury. And also to give them access to outpatient rehabilitation activities for cognitive stimulation. Now, support and cognitive stimulation are both things that could help anyone who's recovering from a traumatic brain injury, but this might be especially important as preliminary results suggest that this population may have a particular absence or lack of social support and cognitive stimulation. So I'm just going to ask if anyone has any sort of quick questions and clarifications. We'll revisit questions again at the end for all of us. So.
I'm wondering, so you looked at social support. Have you also looked at pain as well as anxiety or any mood issues that would differ between the users and non-users? Because I know that's a problem when we do talk to them as why they're using alcohol or marijuana. you looked at that at all? Or?
Yeah, so we did look at anxiety and depression, and there was no significant difference on depression. There was a significant difference on anxiety, but we actually controlled for that in the correlation, and it was still significantly correlated with substance misuse, even taking into consideration the differences in anxiety. But that's a great question, thank you. I'm just going to take maybe one more and then move on. So at the top.
Thank you so much. That was a really interesting study. Question I have also about social support and SES. So I'm probably just not familiar with the measures that you use to link the two. I'm just thinking people who use substances or people who use drugs, from at least from ethnographic research or other forms of qualitative research, actually might have very strong social support networks despite a lower SES. So I'm wondering if you could just clarify that.
Sure, yeah. So again, this is just sort of an observation that we found when we compared the scores on the level of non-support on the PAI. But as you did mention, there may be some people that do have substance misuse, that do have strong networks. From a thesis research, I did sort of extensive reviews of the literature on substance misuse and social support, and there are several cases where people sort of, one of the factors in sort of developing a substance misuse problem is a lack of social support sort of in the home. And also sort of another factor that sort of happens after the substance misuse is that a lot of interpersonal problems may arise from substance misuse, which could then lead to sort of a weakened social support due to sort of interpersonal relationship issues resulting from the substance misuse. But of course, there are definitely some people who have strong social support who do have substance misuse problems. So everyone that still had questions, please hang on to them and we can revisit them at the end. I just wanted to introduce my colleague Michael, who will be talking about traumatic brain injury and homelessness.
All right. Thanks so much, Elena, for the introduction, and thank you to all of you for, as Robin said, choosing to spend your lunch hour with us. Today I'm going to be presenting some results from a scoping review that we did, trying to understand what this relationship between traumatic brain injury and homelessness is, and specifically the psychiatric and cognitive sequelae of injury, and how does that play into the biopsychosocial burden of homelessness. So when I present on this topic, and even in situations as informal as conversations, I like to start by trying to frame things a little bit differently. We all have ideas as to what homelessness is, and what sorts of people become homeless, and what might cause them to become homeless. But in examining this, and specifically the etiology of it, and what's going on here, I found it more helpful if you can keep in mind the question, what would it take for you to become homeless? What set of circumstances and situations or events in your life could end up with an outcome as detrimental as this? So I'm not going to put anyone on the spot, but as I'm going through this, please keep that in the back of your mind. So to start, as Robin mentioned, we're more and more lately we've been starting to realize that there is a very strong relationship between traumatic brain injury and homelessness. With these homeless populations reporting a really disproportionate prevalence of traumatic brain injury as compared to the general population. And perhaps more compellingly, we've been seeing that the majority of studies that examine the temporal relationship between the traumatic brain injury and the onset of homelessness have found that the vast majority of people who report a history of traumatic brain injury who are homeless report that their injury occurred prior to the onset of homelessness. So in conducting this review, this wasn't the primary purpose of it, but we were able to take a look at some of the prevalence data from some of these studies. And what we found was consistent with what's been done in the past, and it's very compelling. We have very high prevalence of traumatic brain injury in these homeless populations. And moreover, if we look at the studies that have examined that temporal relationship, we again see that the vast majority of people who report having suffered an injury report that it happened prior to the onset of homelessness. So in understanding what's going on here and how this, how brain injury might result in this outcome, it's helpful to do that in light of the understanding of what brain injury can do to a person. And so Robin has gone over this a little bit, but this is not a comprehensive list of the vast psychiatric and cognitive sequelae that can come after a brain injury. And when you start to think about somebody who might be precariously employed, who might be vulnerably housed, having to cope with these sequelae of injury, it starts to become a little bit more clear how an injury might result in an outcome as detrimental as homelessness. And so what we set out to do was really just understand these relationships and start to qualify them and start to get a broader picture of how these cognitive and psychiatric sequelae of injury are playing into these cycles of homelessness and how they impact the lives of people who are homeless. So I won't spend too much time on the methodology, but on scoping methodology in particular, but if you have any questions at all, please hang on to them. I'll be happy to answer them at the end. But we found 14 studies that looked at homelessness, traumatic brain injury, and examined them in the context of the psychiatric and cognitive sequelae of injury. Now, to put that in a little bit of perspective, when Dr. Angela Colantonio at Toronto Rehab conducted a systematic review looking at all of the studies that examined that intersection of TBI and homelessness only 5 years ago, they found almost half, they found fewer than, or just over half of what we found in this study, which shows this is really a growing field of research, and this is something that's starting to catch scholarly attention. And so what we found was that in these homeless populations, a history of traumatic brain injury was in fact significantly associated with generally poor mental health, as you might expect, as well as cognitive impairment. Now, interestingly, this cognitive impairment was seen in the general homeless population, but when you narrowed down into subsets of the population that had very serious disorders of mental health, we didn't find that association wasn't significant. But we also found that this was associated with self-reported interpersonal difficulties, which, when you think about it in the context of breaking that cycle of homelessness and accessing supports and navigating sometimes complex mental health support systems, it starts to become a little bit more clear how this cycle can be perpetuated in this manner. Also relevant to what Alana was saying, we found that comorbid alcohol use disorder and a history of TBI resulted in a much higher risk of re-injury than did a history of marijuana use, while both predisposed people to higher risk of injury. And lastly, though we saw higher prevalence of bipolar disorder, depression, anxiety, disorders of mental health more or less across the board, psychosis was less reliably associated with the history of TBI, with some studies showing contentious results. So if we take a step back and we look at this relationship of TBI and homelessness and how they contribute to one another, we found evidence consistent with the idea that this TBI is helping to perpetuate this cycle through this cognitive impairment, as well as the exacerbation and precipitation of these disorders of mental health. And moreover, consistent with the idea that the homeless state may actually be increasing the risk of TBI through the exacerbation of these disorders of mental health as well. The two notable exceptions to this were depression and anxiety, where we found some very interesting results. What we saw was that while TBI seemed to elevate depression and anxiety in these homeless populations, when you looked at how further risk of injury was impacted by comorbid depression and anxiety, what we found was that that depression and anxiety were actually protective factors against future TBI. And so there's a couple ideas as to what might be going on here, but the most compelling perhaps is that the greatest cause of TBI in homeless populations is assault. Now, if you imagine someone who is suffering from depression or anxiety, you may have someone who is withdrawing from these risky situations, and as such, you may see a decreased risk of injury. So the key takeaway from all of this is that we found strong evidence implicating TBI as an important contributor to the biopsychosocial burden of homelessness. Now, what does this mean? This could mean that in high-risk populations, better detection and support for TBI may actually decrease the risk of homelessness. When you look at clinical settings, changing attitudes as to the etiologies of homelessness and who becomes homeless and how to support these people may reduce some very important barriers to care. And lastly, provision of ongoing and accessible TBI-focused therapies may serve to actually mitigate these ongoing cycles of homelessness. Now, if we circle back to the question that I asked you at the beginning, maybe your ideas as to what causes homelessness have changed, and maybe they haven't. But I would argue that regardless of whether you believe the etiology of homelessness is biological or sociological, nobody wants to become homeless. This is not an outcome anyone is looking for. And understanding how these TBI supports may actually play a part of this larger picture, we may be able to mitigate this particularly negative outcome. Thank you. And so at this point, again, I'd like to open the floor for one or two quick questions. And keep in mind, we'll be able to address anything at the end.
So, Michael, you did talk about Angela's work in homelessness. And I'm wondering, did you find anything different in terms of gender, females versus males? You have the assault factor. So do you find with females it occurs after, or is the same prevalence as before they become homeless, they have a TBI?
So that's a really interesting question. Some of the work that Angela has done, and what we saw was unfortunately the same, highlights the fact that there's very little work being done on gender in TBI and homelessness. And so that was one of the major conclusions of our review, although I didn't have time to get into everything today, was that more work really needs to be done on that. We don't have a clear enough picture to begin stratifying that and really understanding how gender plays into this. Okay, so I'd like to introduce Mary Bullis. She's a graduate student in our lab, and she'll be discussing traumatic brain injury and the criminal justice system.
Thank you, Michael, for that introduction. So today I'll be talking about the link between traumatic brain injury, or TBI, and the criminal justice system. In particular, as Dr. Green previously mentioned, we're specifically looking at a criminal diversion program targeting mental health in the Toronto community. So a bit of background about the link between TBI and criminality. So in a study looking at over 1 million citizens of Ontario over a 10-year period, we found that individuals with the history of TBI were 2.5 times more likely to be incarcerated after having committed a crime. So some factors that might be at play that lead them to this increased criminal activity are some of the sequelae that were previously mentioned that are associated with TBI, whether that's increased impulsivity or aggression, irritability, increased risk-taking, as well as poor inhibitory control. So these are all factors that may be at play in this elevated criminal activity. Now, with that in mind, we find that in Ontario prisons, about 43% of prisoners report a history of traumatic brain injury, which is quite the startling statistic. And then for these individuals, we find that once they've been convicted and they exit the prison system, they're more likely to reoffend. So their risk of recidivism or reoffending is elevated compared to the general prison population. Now, despite these startling statistics, we find that there's a dearth of TBI-specific research in prisons.
So first of all, we find that there's a lack of care and services that are specifically targeting TBI, and in general, the research looking at interventions for this population is greatly lacking. So with the center in mind that Dr. Green previously mentioned, and the fact that we're trying to deliver remote interventions to people all across Ontario, what we're aiming to do in this pilot project is to assess the feasibility of remotely delivering cognitive and neuropsychiatric interventions to individuals with TBI who are in the criminal justice system. So to accomplish this, we'll be working with our community partner, the Fred Victor Society. So the Fred Victor Society, they're a social service support program in Toronto, and what they hope to do is provide services to people who are in the criminal justice system to help rehabilitate them back into the community. So specifically, the individuals that we'll be working with are the individuals in the mental health criminal diversion program. So these are people who have been convicted, and rather than being sent to prison or jail, they're sent to Fred Victor, which will provide them with vocational training, help them find housing, or provide them with health services like the one we'll be providing to help them reintegrate into society and sort of move past their criminal record. So obviously, our number one aim with this program is to improve the cognitive and emotional well-being of the clients, but more long-term, what we're hoping to accomplish is to influence policy and guidelines regarding traumatic brain injury and the criminal justice system. So as we saw, with 40% of individuals in prisons having experienced traumatic brain injury, what we really need is early detection of these injuries to help provide early support for people to prevent the negative outcomes stemming from that injury. As well, we want to ensure adequate access to intervention, which is what we're hoping to accomplish by delivering the remote interventions through our tele-rehab center. In addition, we're hoping to reduce recidivism rates. So again, recidivism is the risk of reoffending. So first of all, we'd like to develop measures to potentially measure whether people will have an increased propensity for recidivism. As well, we hope to improve public safety. So for this particular project, our first objective is to determine the feasibility of delivering these remote interventions to this population. So we'll be looking at recruitment strategies, retention in the program, treatment adherence, as well at the end of the program we'll be conducting hopefully semi-structured interviews to look at barriers to adhering to the program and participating in the program, as well as assessing what the individuals thought of the program. And then in addition, we're hoping to assess preliminary efficacy of these interventions. So we'll be looking at patient-reported outcomes such as mood, anger and irritability, and as well propensity for recidivism, like I mentioned before. So one of the existing bodies of literature that exists surrounding around criminality is that people who lack hope are more likely to reoffend. So we're trying to look at scales of hope and hopefulness to determine whether they have an increased propensity for recidivism. As well, one of the things our lab is hoping to accomplish is to develop new measures to identify the risk of recidivism. So our protocol for this project will be, first we'll receive referrals from Fred Victor case managers that work one-on-one with the clients. And then we'll be conducting a screening interview to determine if the clients with a history of traumatic brain injury meet the eligibility criteria for our program. Then a psychologist will conduct an intake interview and a neuropsychological assessment to determine the cognitive status of the clients as well as any of their needs or any of their cognitive or executive function symptoms. And then eventually they'll be transitioned into group teletherapy at Fred Victor. So along with a cohort of 5 of their peers from Fred Victor, we'll be providing them with 3 different modules of tried and true therapies that have been shown to be effective for individuals with traumatic brain injury in the general population. So we'll be administering about 2 months of mindfulness meditation, cognitive behavior therapy, and goal management training. And if you have any questions about those, we can address them at the end. So with this population, there are a few special considerations for us. So first of all, there is a very high risk of attrition when they're enrolling in this program, just because a lot of them are sort of in precarious life situations. They've just been discharged from whatever crime they're committing. They're trying to find housing, employment, so committing to this 2-month period may be difficult for them. In addition, we have a lack of available health records, so these individuals may not necessarily have an OHIP card or a family doctor so we can confirm that they've actually had the traumatic brain injury. However, previous studies have shown that offenders are quite reliable in the reporting of their history of traumatic brain injury, so this shouldn't be too much of a problem for us. As well, by conducting the neuropsychiatric assessment, we'll be able to assess any of their needs ourselves through our therapists and psychologists. In addition, a lot of them have a lack of permanent address or are suffering from, are experiencing homelessness, so that may also be a barrier to them participating in the program. In addition, many of them have a lack of social support, and as we find a lot of times with therapies, people are more motivated to participate when they have people to encourage them to attend the therapy sessions. So we're hoping that we can mitigate this by providing that group teletherapy environment so that their peers can encourage them to participate. And moreover, a lot of them have comorbid substance misuse, which may impede their ability to participate in the program. So some of the implications, rehabilitation implications of this line of work are we really need increased early detection of and support for traumatic brain injury. So if we detect the traumatic brain injury early in life for high-risk populations, maybe we can help mitigate their risk of committing crimes. And as well, if we detect the traumatic brain injury once they're in the prison and provide them with services, perhaps we can reduce the risk of recidivism once they're released. Another thing is changing attitudes towards the etiology of what may cause a person to commit a crime, especially when we consider all these factors that I listed, the substance misuse, the mental health issues, the precarious housing, employment, and all these factors, and understanding that there isn't one single thing that causes a person to commit a crime. And despite this, now that they're in this situation, we need to do our best to reduce that stigma of them having committed the crime so that we can provide them with the best services possible despite their situation. And then, most importantly, ongoing and accessible traumatic brain injury focused therapies during and after incarceration could help potentially mitigate the cycle of crime. So if you've noticed, these implications look very familiar when we're looking at Michael's implications for homelessness when we're looking at traumatic brain injury. So when we're examining these vulnerable populations, while each of them have their unique characteristics and specific needs, there is a lot of overlap in terms of what we can do as researchers and clinicians to help them. So for instance, a lot of these groups have mental health comorbidities that might impede their recovery following a traumatic brain injury, and we need to address these and help them with them. In addition, when we're examining these groups, because of whether they have substance misuse or they're homeless or they're in the criminal justice system, these other issues may overshadow the traumatic brain injury and the sequelae that are occurring as a result of this. So we need to make sure that we're making an active effort to improve detection of the traumatic brain injury so that we can improve their access to services. And as well, we need to address barriers to accessing rehabilitation for these groups and make sure that we're providing additional ongoing support for these vulnerable populations. So just before we get to questions, we'd just like to say thank you to our lab and all the people who have contributed to these projects and the projects that are ongoing with the Brain Discovery and Recovery team, as well as acknowledge all the collaborators that we've worked with for these projects and our sponsors. And so now we'll open the floor up to questions for myself and all of our presenters. We have a couple of points from each of the presentations up here if you need a refresher on what we discussed. And yeah, thank you so much for listening.
Thank you guys. Thank you for such clear and informative and concise presentation. I had one of my few jobs in introducing the presentations was to let you know that we would actually have a 10-minute Q&A at the end, and I forgot to do that. So please feel free to just really informally ask any questions that you might have. Do you need to mic them, or is this okay? Oh, great. I'll start with a question for Alana. Just the population that you were working with who had a history of substance misuse, did they have active substance misuse while they were recovering from their TBIs?
Based on self-reports and sort of details from their clinical and chart work, about 85% of them were no longer using their substances. So what we're looking at is primarily the effects of pre-injury substance misuse as opposed to continued substance misuse.
I have a question about how you measure the level of high substance or low level of high substance misuse, and what is the threshold to determine whether it's a high misuse or low misuse?
Sure. So the question was about how to determine the level of substance misuse, whether I classify it as a high level misuse or within sort of the normal range. We use a scale called the Personality Assessment Inventory, which measures a lot of things, but we looked specifically at the subscales of alcohol problems and marijuana problems. And so those questions sort of ask questions such as, they're statements and they're rated by the participant as being either false, slightly true, mostly true, or very true, and are then scored based on that. And so the statements look something like, for example, for drug use, I've tried just about every type of drug. I've been told that I have a drug problem. For alcohol use, I drink first thing in the morning. Alcohol use has caused me problems in my relationships. Alcohol use has caused me problems at work, that type of thing. So those who scored one or more standard deviations above the mean, we consider to be in the high substance misuse group, indicative that they were having several problems with substance misuse sort of in their day-to-day life. And then those who were within the normal range, we classified into the control group.
Maybe I missed number of participants you had.
So we had 36 participants that were, so in the database itself we have over 150 participants. What we found was that 36 of those fit into the category of high substance misuse. So we case matched each of those to controls that were similar in terms of age, years of education, injury severity, a number of other factors, but just scored within the normal range of substance misuse.
Thank you.
Great question. Yes.
Similar question about homelessness. Is there an easy definition for that? Does it range from couch surfing to staying with Uncle Fred, or are these typical people on a grate?
Yeah, so that's a great question. There's a lot of heterogeneity in what actually is homelessness, and so when you conduct a review like this, usually you're dependent on the author's definitions, but that can range depending on the study. Generally, though, it's defined as someone who doesn't have a permanent address, someone who doesn't reliably have a place to go every night. Many of these studies are focusing on people who are using shelters.
Yeah, street people.
Go ahead, Jim.
My question is about the online support center. Can you give us more information about where it's located, how does it function, what kind of services it does?
Sure. So it's in its earliest stages, and it's located at Toronto Rehab and supported by Toronto Rehab, and also support from donors is in the works, as well as the usual grant support. And it's just getting off the ground in terms of our groups. So we're just running our first set of groups since the center officially got off the ground. The therapist is based at Toronto Rehab, and then patients are based across the province. And patients are always treated in groups. One of the things a little bit more about the center. So some of the therapies are these tried and true therapies like cognitive behavior therapy, as Mary mentioned, goal management training, mindfulness meditation, and these all have known efficacy for mood and cognition. In people in neurological populations, including traumatic brain injury. And we also are undertaking very sort of promising cognitive interventions for memory. All of these interventions, we have a variety of reasons to think will operate at the level of the brain and offset what we've been seeing in a lot of our research, which is deterioration of the hippocampus, the memory structures of the brain across time. And one other thing I wanted to mention is Alex Mahaldis, his student's name was on our collaborator slide, but Alex's name was not. But one of the things that we're trying to do with the center in terms of the interventions is to deliver as many interventions that are really cost effective as possible. So when you've got a therapist at one end, you have to pay for the therapist. But when you have self-administered interventions, like automated, we have one that is an automated spatial navigation task that Michael is involved in, and that is self-administered. So once that's up and running, once it's designed, once the efficacy is demonstrated, it doesn't cost anything to run, and we don't want patients to pay anything at all. But we also have an intervention we call it an anger management bracelet that Alex is the expert on. I'm supervising TACFON how on this intervention, and it's a bracelet that you wear that reads electrophysiological symptoms that can anticipate an outburst of anger and help you to operate in your everyday life a lot better, because this is such a predominant problem for people with traumatic brain injury. Oh, right. Any questions from people who are online? Yes, we have one more minute. Okay, well, we've ended right on time. Thank you very much, everybody, for attending, and thanks again to the speakers.